Well, it's not a case, it's serious. But anyhow, I just wanted to state that this was not done for exhibitionist type of purposes. I'm not an exhibitionist, I'm an interventionalist, but sometimes out of frustration when you don't have other options, or when you have issues with anesthesia, you have to do procedures without anesthesia's presence. So those are the cases that actually were because we felt like this could be done without anesthesia. And I have nothing to disclose related to this procedure. Now, Rosselli and the group from Cleveland Clinic in 2018 proposed a new criteria in designing Zone 0. What includes Zone 0? As you can see, you have A, B, and C. A is involving the valve just below the coronaries, and B is from the coronary arteries to the right pulmonary artery branch, and then C is above all the way involving the innominate artery. I think it's appropriate thing to consider because all those areas play a significant role as far as the risks and the outcomes are concerned. And here are the risks that are included when you consider endovascular repair of the Zone 0, and there are probably more, but some of them are more important than the other. And this presentation is particularly related to Zone A and B in my personal experience. I wanted to share with you there are at least 2 or 3 individuals that were involved in clinical trial, Rania and Dr. Coselli, and this Gore ARISE trial. There's early feasibility trial, and now there's ongoing pivotal trial, and then another trial as well. And I want to share with you experience in 19 patients and what are the outcomes and risks related to current generation research devices for this particular type of anatomy. And you see in the EFS trial, 30-day mortality was dismally high, 18%, and the stroke rate was 6%, endoleak was 12%. And then the second arm in 22 patients with emergency and compassionate use, again, it was not significantly lower outcome, 30-day mortality of 16% roughly. And when you look at the meta-analysis in very different scenarios, but also include a lot of dissections, 30-day mortality was similar, somewhere in the range of 15%. So there are problems, obviously, related to this particular location, and the procedure is related. And so what else can be done? Well, obviously, there are many factors that play a role, and we wanted to look at our personal experience to see if we can reduce mortality and morbidity and also offer early ambulation and shorter hospital stay in patients with Zone 0 pathologies. And not like a RISE trial that included only dissection in early feasibility type 1A, but we looked at just the high-risk patients that had previous redo surgeries, severe coronary disease, heart failure, aortic valve disease, COPD, and other conditions. And those were the patients that were included in this 10 patients that we wanted to share with you now. Pathologies were most frequently pseudoaneurysms, typically post-surgery, type 1 dissections, fusiform aneurysm that are 5 centimeters at least or larger, and also that increased for more than 1 centimeter in diameter in a year or so. And we use only commercially available stent grafts. Now, the technique that we use most of the time is what we call minimalist TEVAR technique that is shown here. All of you are very familiar with it. The bottom line is that the stiff wire is in the ventricle, and that we pace the patient to lower the blood pressure to about 50 millimeters of mercury, because one of the greatest challenges is the movement of the device during the deployment. And a variety of stent grafts were used here. Some of them are not listed here. They're newer, like TX2 and Alpha 2, but also Gore devices. So the first one we did in 2011, the patient was referred by Dr. Denton Cooley that is there. You can see enormous aneurysm, and actually there was an opening just above the coronary artery, and this is more than 10 centimeter aneurysm, and we used the Alpha device, and we used also occluder, Amplitz occluder. That was the the origin of this pseudoaneurysm, and then we publish this information. But there are other cases. Here's an example. What's important is that you have to enter with a nose cone of those devices in the ventricle, and that is a challenge. So you have to have a stiff curved wire to prevent any trauma or damage to the ventricle. And then you can see the 6-month outcome with excellent results. Now, here you can see some of the fusiform aneurysms. Here is a 5-centimeter aneurysm, and then on follow-up at 6 months, it reduces to 4 centimeters. So those are all encouraging results. So our experience in 10 patients, 6 were pseudoaneurysms, 2 were dissections, and 2 were fusiform aneurysm. There was no procedural mortality, and there was only one access site complication related to the proglide that was surgically repaired and the local anesthesia. There was 2 patients had long-term mortality, but none related to the procedure, lymphoma and heart failure. And there were no endoleaks, no migration, and no reinterventions needed. So what about when we have a zone 0A? That means it involves the aortic valve. So at the present time, we really don't have any solution for it unless we improvise. But what about the use of endobental as an option? And the Brazilian group published one case several years ago with a modified Braille device, and they report satisfactory early result, but there are uncertain outcomes. So I'm very much interested, and I was in touch with Dr. Quadri, who's in Connecticut, and he has this unique device, Veritas device, so-called endobental, that has a very unique flexibility of the coronary limbs. He calls it chameleon eye because really there is no kinking involved. And as you can see here in this animal study, the device is placed in the ascending aorta, and the first part that opens up are those chameleon eyes, and then you cannulate the coronary arteries, and you put stent grafts in the coronary arteries. And then the second part is deployment of the ascending aortic component, and the last one is the valve that's being deployed. And then at the end of the procedure, you can see a beautiful patency of the coronary arteries, and this is going to start pretty soon in EFS. So what can we say? That zone 0 pathologies are truly challenging with current generation devices, and definitely there is a need for future improvement of devices for this application. Our personal experience reveals that improperly selected patients that are not suitable for open repair, TEVAR is feasible and offers significant benefits. Zone 0, I believe, requires a multidisciplinary approach in addition to an interventional cardiologist as far as coronary cannulation is concerned. A vascular surgeon or preferably cardiothoracic surgeon is needed. In future, endobental and endoweed procedure, TAVR and TEVAR might solve some of those problems that are currently major challenges for endovascular repair. Thank you very much.